Hello and welcome to the April video, where we discuss 4 of the most important papers in this month's issue of the Journal of Vascular Surgery. The editor's choice for this month is a paper from Case Western Reserve, Evaluating Strategies for Reducing Scattered Radiation in a Fixed Hybrid Operating Room Suite by Miller and colleagues. They analyzed 164 endovascular cases for methods of reducing scatter radiation, using 3 separate methods. First, routine lead and time controls, versus second, real-time radiation dose monitoring, and finally by using a software imaging algorithm. The authors found that the total mean fluoroscopy time did not differ with the 3 approaches, but that the algorithm approach reduced radiation dose significantly over both routine radiation safety and real-time feedback. The authors believe that a software algorithm will become routine in hybrid ORs to reduce radiation exposure, and this will ultimately reduce the long-term consequences of excessive radiation exposure. The next paper, The Incidence and Risk Factors of Retrograde Type A Dissection and Stent Graft-Induced New Entry After Thoracic Endovascular Aortic Repair, by Ma and co-workers from Shanghai and London, is a retrospective study of 852 patients who underwent stent grafting for type B aortic dissection to determine which risk factors were related to stenting-induced new entries and retrograde dissection. A retrograde dissection developed in 3%, and a stent graft-induced new entry developed in 3.5%. Marfan syndrome, T-bar and a chronic dissection, a stent graft with a connecting bar, and a stent graft length of less than 165 centimeters predicted retrograde dissection, and stent graft-induced new entry. There were no differences between proximal bare stents and non-bare stents. However, a greater oversizing ratio was related to a stent graft-induced retrograde dissection. The authors suggest that improvements are needed in new stent graft designs for aortic dissections to reduce these 2 problems. The next paper, Racial Disparities in Outcomes Following Intact Abdominal Aortic Aneurysm Repair, by Deary et al., is a Vascular Quality Initiative paper of 22,000 patients who underwent an elective aneurysm repair, a AAA repair, using both endo and open techniques from 2003 to 2017. Black patients were more likely to be symptomatic and undergo an endovascular aneurysm repair. There were no differences in 30-day mortality after EVAR or open repair. However, Black patients were more likely to receive new postoperative dialysis and to return to the operating room, and the mean hospital length of stay was longer in Black patients, although after both EVAR and after open repair. The authors concluded that although perioperative mortality is comparable across races after abdominal aortic aneurysm repair, Black patients are more likely to develop new postoperative renal failure and return to the operating room, even after adjusting for differences in comorbidities, operative variables, and hospital volume. The last paper, Characterization and Outcomes of Reinterventions in FDA-approved versus trial endovascular aneurysm repair devices, by Fairman and co-authors from the University of Pennsylvania, addressed the reintervention rates for approved devices versus investigational EVAR devices for the treatment of abdominal aortic aneurysms. This was a retrospective study from 2000 to 2016. At a median follow-up of 5 years, the overall survival was 70%, and the overall reintervention rate was 7.5%. FDA-approved devices were intervened on at a rate of 6.4%, while devices in trials had a 14.4% reintervention rate. The most common type of reintervention was a type 2 endoleak, performed in 52% of reinterventions, while type 1 endoleaks were treated in 18%. There were also type 3 endoleaks in 9.5%, limb kinks in 7.3%, and iliac occlusive disease in 5.8%. The overall mean time to first reintervention was just over 2 years. Among patients requiring reintervention, the mean number of reinterventions for trial devices was significantly greater than that for FDA-approved devices at 2.18 versus 1.65. And trial devices requiring reintervention had a nearly threefold higher odds for needing more than 2 reinterventions. But trial devices, cause of reintervention, and type of reintervention were not predictive of the need for explantation of the graft or mortality. The authors concluded that patients undergoing EVARs with trial devices are more likely to undergo a greater number of reinterventions than with FDA-approved devices, and that investigators need to properly inform patients willing to partake of these investigational device trials. We hope you enjoy this month's Journal of Vascular Surgery. Thank you.